You're listening to The Q Switch with your host, Spence.
Welcome one and all to the Q Switch Conversations podcast. I'm your host, Spence. The mission of this show is to tackle subjects impacting ophthalmology and pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's jump right in. In this episode of the Q Switch, we are joined by Dr. Manju Subramanian, who is a retina specialist. She is also an associate professor and vice chair at Boston University, Chobanian and Avedisian School of Medicine and Boston Medical Center. Dr. Subramanian, thank you for coming on. Where are you calling from today?
I'm calling here from Boston University and Boston Medical Center. How are you?
Fine, thanks so much for asking. So in this episode, we'll be discussing the growing pains of ophthalmic practices in the academic space. The Boston area is chock full of academic institutions, and so tell us about the school that you're associated with.
So Boston University, has an undergraduate campus, and then they have a medical campus that's actually in the city of Boston, in the South End district of Boston, and it's right next to Boston Medical Center, which is the largest safety net hospital in Massachusetts and in New England. And we serve the majority of the city of Boston on the South End, Dorchester region, and in a lot of areas that are typically underserved. A lot of the neighborhood health centers that were originally created by Teddy Kennedy to help underserved populations and sort of meet their needs in their neighborhoods. Places like Upham's Corner Health Center, Dorchester House, South End Community Health Center, South Boston Community Health Center. Boston Medical Center is sort of their primary referral base. And so we have a very rich history and a very strong collaboration with the medical school, which is Boston University Chobanian and Avedisian School of Medicine, which many, many years ago was the very first women's medical school in the country. And then, eventually became a co-educational medical school. This was back in the late 1800s. I can't remember the exact date.
Great. It's great to meet you and have you on. To start, can you describe the current landscape of ophthalmology with academics and academic centers like Boston Medical Center, and what distinguishes it from private or community-based practices?
So I would say that ophthalmologists in academic health centers are often different from those in practice in that you're really working in an institution where you're providing multi-specialty tertiary care, right? And so how this is distinctly different from, for example, the private world, in that most of the practitioners in private practice are their own entity specializing just eye care. Now, over time, a lot of these private groups, practice groups, who provide wonderful and excellent care to a large community in the greater Boston area, now do often have to have hospital affiliations. So the providers in those organizations have affiliations, and over time, it's been nice because they've been coming on to a lot of those hospital medical records too. It makes being able to visualize the notes, when patients who are seen at academic health centers and also seen in private practices. It's, over time, that's been made a little bit easier because now we have access to some of those records through the electronic health record system. Mm-hmm. Typically, in most academic health centers, at least in Boston, that's Epic.
Okay, good.
So I guess your question was, how are they different? And I would say that being in academics, we tend to be teaching hospitals. We train residents. We have medical students that work with us. Then they go into their residencies, and then we also train fellows into the subspecialties, the different subspecialties in eye care. So that is one distinctive difference. And then the other is that we are often the primary referral base for some practices in and around the greater metro area of Boston. Depending on which academic institution you're in, you're sometimes drawing patients from other states, including New Hampshire and Maine and Vermont and Rhode Island even.
Well, I've spent a lot of my time when I was with Alcon in their academic division as an academic manager, and turns out that all the most difficult, most complex cases that are seen get filtered to and funneled to the academic spaces and all across the country. Kind of the standard practice, because they take more time, more expertise than a community-based or private practitioner would want to invest or can really provide. And so a place like yours and others like it, I think, again, they get stress tested quite a bit based on some of the higher volume of complex cases.
No, that's actually quite true. The other side of that is that as an academic health center, we do have access to other, like for example, if someone comes in with a motor vehicle accident, for example, and they have an eye injury, and or say that their primary problem is the eye injury, those private settings are not really equipped, as you said, to manage that, because sometimes those patients will require additional care. Like if they have a fracture around the eye, then they need to see sometimes a tertiary care specialist who is not an ophthalmologist. For example, maybe they need to see an ENT specialist or a facial plastic surgeon. And all that can be provided in an academic environment as opposed to a private environment. And I think providers in the private world of ophthalmology recognize that, and so are able to facilitate the transport by recommending patients that go to these tertiary care centers. So that's one example of where having that access to additional subspecialties that overlap sometimes with ophthalmic care is important for some patients, depending on their clinical situation.
Sure. Well, those are two very good distinctions. I think that they make a lot of sense. So let's talk about the actual growing pains. So when we talk about growing pains in the academic ophthalmology space, what does that phrase mean to you? And are there specific systematic pressures or changes you're experiencing firsthand?
Yeah, so I would say that, some of the growing pains, and I think some of it may be unique to my institution as a safety net hospital,
Mm-hmm.
but I think also could be applied to many academic health centers, which are traditionally not-for-profit institutions. And, a lot of it is just, for providers in particular, and I think what I'm about to say is quite universal, in that payments to physicians have been decreasing and haven't really even kept up with inflation over the years. I would say over the last 20, 30 years. And I think how that impacts academic health centers disproportionately is that academic health centers do not restrict their patients based on the type of insurance coverage that they have, whereas private offices often have to, because they're just not able to maintain a sustainable business model if they accept patients who have either state-funded Medicaid, typically the Medicaid insurance, or no coverage at all. Now, we sometimes see less of this in Massachusetts because we've had universal health care for many years, even before the Affordable Care Act. So I think the state has done a nice job in making sure most members of Massachusetts have health care coverage. There have also been several accountable care organizations that have come about as a result of these changes in the healthcare payment landscape in Massachusetts. For example, Boston Medical Center has its own accountable care organization, and they also have their own insurance vehicle that they provide for patients. But those types of changes, it can make ophthalmologists who practice in healthcare feel like their salaries may not be keeping up with those in the private world. That being said, there are advantages to being in the academic health center, such as the opportunity to be able to teach residents and fellows and really be involved in cutting edge research that are really not offered to people in the private world. And so it's a conscious choice that any physician makes anytime they're finishing up their residency or fellowship. Is they're sort of faced with that juncture of should we go into private or should we want to stay in academics? And they're often very, very different worlds. But in talking to my colleagues around the country, some of whom are in the private world and others whom are in the academic world, when we go to our National Society meetings, there are certainly pluses and minuses to both. I would say one of the biggest challenges, to answer your question, is that really how are we going to pay for healthcare for our patients? How are hospitals able to maintain a sustainable financial model based on, the type of hospital they are, whether they're a community hospital, whether they're an academic healthcare, whether they are a safety net hospital. There are many different phenotypes, and the financial models are very different for each of those. So I think, just like with anything else, it's complicated, and I think something that is going to be interesting to see how it sort of plays out, especially in the current political climate.
Yeah, agreed. So switching gears just a little bit, you mentioned a couple things just now that really tie into my next question. So one common tension is balancing academic productivity with teaching and research, which you mentioned. How has the tension evolved in recent years, and what impact does it have on faculty engagement and patient care?
Yeah. So There's been a fair amount of data that's come out talking about physician well-being and physician burnout, which seems to be a real challenge, especially if you look at the data over the last 10 years. Physicians are burning out at increasingly higher rates. The causes are multifactorial. I think the physicians feel, particularly in the academic health centers, that there's a larger administrative burden placed on them in terms of having to document in the medical record, getting less administrative support for some of the aspects of their care that are clinical aspects of the care, but that can often be managed by nurses or administrative assistants in terms of answering phone calls and answering patient messages. As one concrete example, prior to the inception of EMRs, patient phone calls went, and this still happens in the private world, where patients will call a physician's office and the staff will answer the phone call, they'll take the message, and sometimes the staff are trained to answer some of those questions themselves. Well, now patients can directly message their providers in their MyChart, in their electronic health record. And if there isn't a process in place for that provider to have somebody else help them check the messages, the providers are responsible for checking those messages themselves. And so that's one example of how the administrative burden on physicians has been increased over time. And they think that may be one of the contributions to affecting physician well-being. So in terms of other aspects of academic healthcare, I think teaching is certainly, for a lot of doctors, a great pleasure and is something that they enjoy doing very much. Teaching is not really paid for. I think, similar to the private world, most of the funding that helps with a physician support a physician's salary is generated almost exclusively from patient care. So the teaching is actually done on a voluntary basis for most providers. The clinical bedside teaching, that is, we're actually not paid to do that. It's an expectation as part of being in an academic institution. You can be in an academic health center and be primarily clinical, or you can be in an academic health center and be primarily a research clinician scientist. You are funded with, whether it's NIH grants or industry grants or Department of Defense grants, and you have projects that you are working on that help to support your salary. So if you have those grants, then you are considered funded, and so you can allocate time in your schedule for that research. Some doctors will do research but not have funding for it, and that is perfectly their choice, and it's fine. But I think, for the most part, if you're in academic health, if you don't have funding for research, then most of your funding comes from clinical care of patients. So sort of balancing those three different mandates, teaching, research, and clinical care, I would say is a big challenge for a lot of doctors in general, not just ophthalmologists.
Yeah, well, you mentioned a couple of times here during our conversation so far about the financial pressures, let's just call it, and some of the institutional expectations. So how do financial models at academic centers influence decision-making on ophthalmic departments? Is there a risk of compromising long-term academic goals for short-term financial metrics?
No, I think that interplay and those conflicting mandates are always, going to be present in an academic health center. So I would say, yes, the hospitals, in our institution, for example, the hospital has certain volume goals that they want each individual department to meet, not just ophthalmology, but every individual department. And so those goals are set, while you're working with the hospital for that budget year, the year before. So that could be one example of a short-term metric that you call. And then meeting those metrics can sometimes be challenging, because what if you have a provider that goes on parental leave, for example, or say they have to go on medical leave to get knee surgery. So in those cases, we aren't always able to meet as this one example, our volume metrics, to making sure we're seeing a certain number of patients, because seeing that certain number of patients is what helps keep the institution viable financially.
Sure.
Right? And so those are some examples of, you budget for certain things and you don't always achieve your budgets. The emphasis on financial viability for the individual department can sometimes get in the way for a provider to be able to really devote their time and energy into the other aspects of academic medicine, which is teaching and research.
So, obviously that's a whole another layer of pressure, but you mentioned burnout earlier. So when talking about recruitment and retention challenges, Are you seeing challenges in recruiting or retaining faculty, especially comprehensive ophthalmologists? And what role do workload, compensation, or academic pressures play in this dynamic?
So to your first question, are we having trouble recruiting comprehensive ophthalmologists? I would say not. It really is very subspecialty dependent in ophthalmology.
Okay.
So I would say for us, we struggle with recruiting a glaucoma specialist, for example.
Okay.
Comprehensive ophthalmologist has not really been that much of a challenge for us. Our institution tries to do a good job of trying to maintain salaries to be at benchmark, because there is data out there that benchmarks, quote unquote, benchmarks physician salaries based on subspecialty and based on academic rank. And that's data that hospital systems have access to. So in order for a place like Boston Medical Center to be competitive with, other academic institutions such as, Tufts Medical Center and Mass General Brigham, they recognize that they have to, offer salaries that are close to benchmark for physicians based on their subspecialty. And I think they do a relatively good job of doing that. So I think the challenges that we're having with glaucoma recruitment are less related to compensation packages, but more related to the increasing demand that people have, the increasing demand for glaucoma care, number one, and the lack of glaucoma specialists in the field, the shortage of glaucoma specialists for the field. It seems like everyone that I know is looking for a glaucoma specialist.
So let's talk about equity, access, and mission-driven care, which I'd like to ask you about next. So academic centers like BMC often serve diverse and underserved populations. How do you maintain mission-driven care amid operational and financial constraints?
This is a challenge that's unique to most hospitals. And I think being a safety net hospital, we probably see this more than other academic health centers. But I do feel like other academic health centers also, are met with this challenge. So the answer is that you really just have to have good hospital leadership to really and make sure that they're engaging the physicians in how they both communicate their vision and the mission of the hospital. And I do think Boston Medical Center does really an excellent job of engaging their physicians in that way. And I think people who work and not just the physicians, but even the other licensed independent practitioners, nurse practitioners and physician assistants and, for example, in our field, optometrists, people who work here really believe in the mission, and they really believe that equity and equal access in care is, one of the most important challenges in healthcare, an extremely important part of what we do. So I feel like most providers who work at Boston Medical Centers are really proud to be here. Mm-hmm. So everyone sort of works towards that mission. And I would say our institution does a really fantastic job of not just trying to deliver healthcare in an equitable way, but they also have other things. I can give you one small example. A pediatrician who had the idea of helping patients. She recognized that some of her patients' parents and families were struggling with filling out their tax returns. And so she went to her chair to say, I want to start a program that will help our patients' families with their tax returns. And you would think, why are hospitals and departments getting involved in tax returns? So, but this idea was actually, she just asked for just a little bit of seed money, which her chair supported her. This is Dr. Bob Vinci with pediatrics. Her chair supported her in this. And now it's a program at BMC. And as another example, our senior vice president for space and campus redesign, Bob Biggio, has worked towards creating a very futuristic, sustainable, climate-friendly hospital over the years. I gave a talk to our department talking about how he has redesigned the campus in a way that allows for the campus to be quite sustainable. And one of the projects and one of the physicians came to him and said, wouldn't it be great if we utilize some of the energy savings that we have to benefit families to help them pay their bills, their heating costs over the winter? Mm-hmm. And so they worked it out so that they actually provide some families in the area an opportunity to be able to and I don't know all the details around this, but they do help these families with their energy costs.
Wow. I mean, in a place like Boston where obviously it gets cold and you get the
Yes.
snow and all that stuff where, I mean, paying your heating bill is kind of important, especially if you
Right.
get little kids. So, I mean, and doing that kind of work outside of just like direct patient care,
Yes.
some of that community outreach and support, and again, given the communities that you serve, I think it's absolutely critical. And it's got to be on your heart. It's not for everybody. It's got to be your calling. And it sounds like you and the rest of your crew at BMC have certainly answered that call.
Yes, I think so. I think people who work here are very proud to work here.
So we've identified a lot of the growing pains. There's very many layers to it, seems like. In light of these growing pains, are there any innovative approaches you or your department are exploring, whether in care delivery, education, or administration? And some I think you actually just mentioned, but if there's any more.
So I would say in terms of care delivery, we have a provider here who during his medical school days worked with Boston Healthcare for the Homeless, and he still has a great deal of interest in working with the homeless population. And so we are working on a model to where we can do vision screenings with homeless. We have several shelters in the Boston Medical Center area where we are. So I know that's very, very much in the early stages, but those are some of those. That's one initiative that we're working on. In the world of physician well-being, I'm actively involved in as vice chair in the faculty development and career engagement of our clinical faculty, and I believe increasing their engagement will help reduce burnout. And one of the things that we have implemented is an executive coaching program for our faculty that we implemented during the 2023-2024 academic year, and based on pre and post surveys, we think that was quite successful. And so those are two things that I can think of off the top of my head. And I think I already spoke to a little bit about what the hospital's doing at a hospital level.
Mm-hmm. Looking forward, if you could change one thing about the academic ophthalmic environment to ease these growing pains, what would it be? And what gives you the optimism for the future of academic ophthalmology?
So I would say if I had to change one thing, I would say to come up with a way to recognize the teaching that the academic ophthalmologists do on a day-to-day basis that's just sort of integrated into their job and not necessarily recognized. It's certainly not recognized financially. It creates, I would say, a lot of internal gratification. Teaching for some people is highly rewarding, but it largely goes unrecognized, at least from a financial remuneration perspective, right? So I would say if I had to change one thing, that would probably be on one of the top on my list. And then what was the second part of your question again?
Oh, the second part was what gives you optimism for the future of academic ophthalmology?
Yeah, I mean, I think in the, as the world is talking about artificial intelligence, right? Everyone sort of wonders how that's going to impact them, and their jobs, right? Eventually. But I do think that you're always going to need teachers. I think you're always going to need physicians. You're always going to need people that are going to need their health. People are always going to need someone to help take care of their health. So I feel like, being in academic ophthalmology will always put you on the cutting edge. And if you choose to be a leader in your field, you really can be a leader in your field. So I think that's what gives me optimism.
Well, Doc, thanks. That was absolutely amazing. I love it when people come onto the show and they speak their real world experiences and their truth. And it seems like you really have a depth of knowledge and understanding of the subject, and you really enjoy what you do in the environment with which you do it. So I want to thank you for really spending time with us and imparting your wisdom and knowledge here on the show. And I would say that if there are any academic institutions out there that listen to this show, I'm sure they will take up on all your advice and enjoy what you've shared.
Thank you.
So it was a pleasure having you on the show. Thanks a lot, Doc, for coming on. I really do appreciate it. Before we sign off, if there's any of our listeners that wanted to connect with you to talk more about the subject, where can they find you?
Oh, yeah. My email, I believe, is on my website. And so they can reach out to me without a problem. I take questions from people all the time.
Oh, great.
Thanks you for having me, David. I really enjoyed it.
Good. I'm glad you came on the show and we were able to have the conversation. So as always, we'd like to thank Riverside FM and Passionate Media for making this show possible. That's a wrap for this episode of the Q Switch Conversations podcast. Until next time, this is Spence and I'm out.